Okay, so the last class we were discussing about the treatment of we were discussing about the condylar fracture. So continuing with the treatment of condylar fracture. So it may be either conservative or surgical. Okay, conservative or surgical, depending upon the severity of the fracture, severity of the trauma. So the conservative treatment, it is basically close reduction. The basically close reduction, we will not open the side where the fracture is there. We'll just put the patient on arch bar and intramaxillary fixation for the period of 2 to 3 weeks, so that the fracture will get healed on the previous normal anatomical position. Yeah. Then surgical treatment that involves open reduction. We'll surgically open the area through some extra approaches. We'll see the fracture, we'll reduce the fracture, and we'll fix it with either direct wiring or mini plates or rods or whatever it may be, and we will replace the fracture back to its normal anatomical position. So that is a treatment protocol for treatment of condylar fracture. Yeah. So if there is a minimal displacement of the condyle, fracture of the condyle, minimal displacement, and if there is a normal occlusion is there, we just put the patient on elastics or just parallel bandages with immobilization. And if there is a persistent malocclusion with severe pain, we'll prescribe the patient to IMF. We'll treat the patient with intramaxillary fixation for 7 to 10 days until the edema and the muscle spasm disappears. And if it's a bilateral condylar fracture, we'll put IMF for the period of 3 to 4 weeks with posterior distraction block. Means if there's a bilateral condylar fracture, what happened is that there will be shortening of the mandible length will be there. So to not maintain the vertical dimension or to keep the mandible in the normal position, in terms of vertical dimension, we'll keep a distraction block in the form of an impression compound, and elastic traction will be necessary to guide the teeth in the normal occlusion. Okay, so this is the picture where you can appreciate again where we have given upper and lower arch bar is given, and we have guided the teeth to elastics with the elastics, and we have kept the teeth in the normal occlusion. Intramaxillary fixation is also given. So this is a classical example of close flexion of fracture. Now, the indication, which all cases we go for open reduction of fracture. There is a fracture dislocation of the condyle into the middle cranial fossa. So if the fracture dislocation happens and it gets displaced in the middle cranial fossa, what happened will be that the patient will have CSF leakage. So we have to reduce the fracture, take out the condyle from the middle cranial fossa, fix it. We have to go for open reduction. Or there's a lateral fracture, it is dislocation of the condyle, where there will be vertical shortening of the length of the mandible. Or the third case scenario is that we have tried for a close reduction, but it's not getting replaced back to normal anatomical position. In such a case, we'll go for open reduction. And if there is an invasion of foreign body, there is a compound fracture, there will be there will be some foreign bodies will get invaded to the fracture site, making into a compound fracture. So that's a feature of a compound fracture, or in the case of a gunshot wound angle, we have to open, take out the foreign body, we have to clean the area, and we have to reduce, fix it, and mobilize with the mini plates or lax screws. And the relative indications are that if the patient is not amendable for a close reduction, because in close reduction we have to keep the patient's mouth closed. Like we have to keep the patient's mouth closed for so and so amount of time. So mentally retarded patient or epileptic patient will not tolerate such kind of a procedure. So we'll, or the patient with severe respiratory distress, where the mouth is being asked to keep closed for the period of 2 to 3 weeks. It's not amenable for those kind of patients. So such kind of patient can go for open reduction. Or if there is a bilateral fracture of condyle with complicated midface fracture or complicated kind of fracture, it's always better to go for an open reduction and replace the fracture as part of the normal anatomical position. Then in the case of pediatric fracture condyle of dangerous patient, the atrophic splinting is not recommended. So not to go for a close reduction, it's vital that we need teeth. So whenever the occlusion is achieved, we assume that the teeth, the fracture has been replaced back to its anatomical position. So in the case of fracture condyle with irregulous atrophic ridges, in, you don't have any teeth to put in the IMF, or in the case of atrophic ridges also we cannot put a gunning split. In such a case also we have to go for open fixation of the fracture for contact. Yeah. Then the treatment, so there are three modalities, that is the reduction, fixation, and the immobilization. We have told about the close reduction, we told about the open reduction and fixation by internal fixation or external fixation, or by arch bar and by wire. So in the fixation that we have already told, it can be by transverse plating. We have the mini plates that's being used now. Then we have the eccentric dynamic or dynamic compression plates is there. Then screws is there, lag screws there. Then intramedullary rods can also be used for immobilization also. So this is the surgical approaches. First, we have the preauricular incision. So the preauricular incision will make the incision or anterior to the tragus. We will dissect the skin, the subcutaneous tissue. Below the subcutaneous tissue, we have the superficial fascia. Below the superficial fascia, the facial nerve branches will be traversing below the superficial fascia. So we'll find the zygomatic arch in that region. But we'll find the zygomatic arch in that region, and we'll make an incision 45 degrees to the zygomatic arch. Then we'll dissect the plane between the superficial and deep fascia. You reach the zygomatic arch, and we will give vertical incision, and we'll see the condyle. So in order to treat any kind of high condylar fractures, we go for a preauricular incision. Then we have the post-auricular incision 3.5 centimeters from the posterior tragal region. Then we have the post-ramal incision, or the classical submandibular or retromandibular incision. So in this incision, we'll start the incision around 0.5 to 1 centimeter below the ear lobe, and the length of the incision is around 1.5 centimeter from the ramus to the lower border of the mandible. Incise the skin, the subcutaneous tissue. Below the tissue, we have the superficial fascia. Below the fascia, we have our platysma muscle. Below the platysma muscle, we have the parotid gland capsule will be there. Then we have to either cap of a transparotid approach. The transparotid approach means we will go reach the contact through the parotid. So the region of parotid between the marginal mandibular branch of facial nerve and the buccal branch of facial nerve, there is a plane where there is no structures in the parotid. So we dissect that part of the parotid when between these two nerves, and after dissecting to the parotid gland, will reach the masseter strip of the masseter and will be reaching to the ramus and subcondylar region of the mandible. And so where we can approach to the low condylar or high condylar fracture through the classical retromandibular incision. And if you want to address a low condylar fracture or condyle ramus fracture, always go for a safe submandibular incision, where we place the incision to finger below the bottom of the mandible. This is a maneuver to protect the marginal mandibular branch of patient nerve from getting damage, which is found on the sap platysma. So we incise the skin, the subcutaneous tissue. Below the subcutaneous tissue, we have the superficial fascia. Below that, we have the platysma, and the subcutaneous platysma. We have the marginal mandibular branch of facial, which will already get retracted because we have placed the incision to finger below the mandible. Then we have the deep fascia. Below the deep fascia, we have the facial artery and facial vein. They are connected together. So both the vessels has to be lighted to get proper reflection. And below the deep fascia, we have the masseter sling, and that is a least vascular area of the mandible. So we strip off the masseter sling by the blade or a cautery, and so we reach the lower of the mandible angle region. Then the strip of masseter to get access to the subcondylar region. So it's difficult to address high condylar fracture with the subcondylar incision. Always address low condylar fracture or artificial fracture with the subcondylar, so submandibular rate of incision. Yeah. So in this picture, we can see how we fix the condylar fracture. So the condylar fracture, most of the condylar fractures will be displaced because of the pull of the lateral muscle. So we with the use of a certain system like a cropper or something, we can pull the mandible down, push the mandible down, fix the pressure, and typically reduce the fracture, displace the condylar and get fixed with the mini plate like this. Two mini plates can be fixed and reduced, or either we can use intramedullary rods or lag screws can be used. So these are the methods to fix the condylar fracture. Now, the problem with pediatric condylar fracture is that in the case of the children, it has already has a growth potential. So, in the case of condylar fracture, in the case of kids, they will have a thick condylar neck. So, condylar neck will be fractured, condylar head will be fractured. So, sometimes fracture the condylar head will cause damage to the articulate meniscus. So, if there is a fracture in the articulate meniscus, they will directly get contact with the fossa, so we will present an ankylosis in the case of pediatric fracture patients. So the ankylosis can further precipitate into the blood phase or necrosis. It's a case of bilateral deepening of the antimonial notch or post facial asymmetry can be there. So then surgical complication for this condylar fracture, which is a transient permanent facial palsy when we are accessing classical transported we have the retroperative approach. So if we go for a transported approach, so we think that the marginal mandibular nerve cannot second damage if we do a classical submandibular approach, rear lobe hypostachial the damage of orbital nerve and post-surgical scarring of the previously treated surgical ties. Then auricular temporal syndrome is there, or phrase syndrome, gestatory respected with the damage of auricular temporal nerve. Then masseter myotonia because of the spasm of the muscle immediately fracture will be the condylar head resorption. Can also be there if there is a deficiency of blood supply or excessive force acting on the condylar post fixation. So this is anticipated modification for the condylar fracture. Yeah. So that's all about condylar fracture. Thank you.